Good morning, and thank you for joining us for this episode of SBB Live. I am your host and the publisher, Seniors Blue Book, Amanda Barton. Really excited to bring on the show today, Miss Lisa Mann, who's over at Park Royal Hospital. How are you this morning, Lisa?
I'm doing pretty good. How are you?
Really good, thank you. I know our topic today is one that's of a sensitive manner, but it's something that absolutely needs to be discussed. So, talk to me a little bit about suicide. What are you guys seeing there at the hospital?
So I've been with Park Royal Hospital for almost 3 years now, and I've definitely seen a huge increase in both depression, anxiety, suicidal ideation, bipolar disorder. I think a lot of that is due to the growth in the area, as we know a lot of people are moving here. I think also part of that is people just becoming more accepting of talking about mental health and being able to reach out and accepting referrals by their primary care. But something that I did notice a very drastic change was with the pandemic. And I think a lot of factors related to that were the isolation people were feeling, like not having their social events, going to church, farmers market, yoga, whatever it was that they were doing to stay connected. Of course, financial implications, job loss, concerns about possibly losing their job if they were furloughed. And a lot of people experienced death or serious long-term complications related to the pandemic. So I think more recently we've seen a huge increase in depression and anxiety.
Yeah, for sure. It has been a really rough couple of years, that's for sure. But I do think that we're breaking the stigma on talking about mental health. Talk to me a little bit about, I want to dive into, tell me a little bit about Park Royal and yourself, and then, our specialty dealing with geriatrics. Talk to me about, suicide amongst the elderly as well.
Yeah, so I have a wide range of experience with different types of patients, everything from pediatric to geriatric, and everything from just mild anxiety to severe schizophrenia, schizoaffective. And with our geriatric population here, that's a population that is, when I walked by one of the supervising doctors I work with, I said, "Hey, I'm going to be talking about geriatric patients. Is there anything you'd like to throw in?" And he said, "That is the most high risk population." And he said, "That's my one point, is that as a population, we really want to keep an eye on." And the reason for that is just they're at the end stage of life. It's not a secret. They know it. We know it. And it's something that can be very hard to deal with because even though you have many years left after you're technically geriatric at 65, you have a lot of things that are over. Like certain parts of your life are over. You're never going to be, if you were into sports, you're never going to be playing soccer the way you used to. Or if you're really into gardening, you're never going to be able to be on your knees for as long as you were gardening. And the limitations can be extremely depressing, as well as the seeing loved ones pass away, seeing friends pass away. It's something that's very personal to me because I'm the baby of the family. So all of my relatives are much, much, much older than me. And so I've watched, things like stroke or heart attack or loss of their siblings or being the caretaker. Sometimes we have elderly people being the caretaker of another elderly person, like their spouse or sibling. These are huge stressors and they do contribute to suicidal ideation.
So, Lisa, what are some of the other common misconceptions that folks have about suicide rates and facts and figures, if you will?
So in a broad sense, just looking at all age groups, a lot of people are hesitant to seek help because of cultural stigma. So I'm seeing a lot of Miami transplants like myself. I grew up in Miami. And, my mother being Cuban, it was very much not something that was discussed openly. And it was considered, be careful because then people will think you're unstable and people will think that maybe this reflects badly on your parenting or your family that you have these conditions. So that's something I'm mindful of, especially elderly patients. They are very kind of set in their ways. They're not seeing all these uplifting pro mental health articles on the internet because they're really not on the internet. Their beliefs are more founded in their childhood and how they grew up. Other common misconceptions with elderly patients is that it's normal for them to be depressed, like it's normal for them to have no energy, no appetite, be fatigued, to be isolated, to just watch TV all day. We can't just accept this as like, oh, this is going to be their quality of life. We want to see if we can optimize their mood, whether it's through supplements or medications or therapy or activity. And just from a medical standpoint, a common misconception is that more medication is better. In a lot of cases, these patients can be over medicated and that can contribute to the depression. So it's really about taking a thorough look at like what the symptoms are and how they're being treated.
Yeah, no, I couldn't agree more. And there's a really scary statistic that I learned by listening to one of your seminars recently about just the geriatric population being at the highest risk of suicide, and those numbers are astronomically scary. So tell me, what is that statistic, or what's the age group that has like the highest rate of suicide?
So the highest rate of suicide would be in Caucasian males that are older than 65 years old. And we have to kind of look at suicide risk as a math equation. And so we're looking at it as risk factors. So the demographic group versus social factors like isolation, medical factors like loss of mobility through stroke or something like that. And also looking at co-occurring issues like substance abuse or possibly personality disorders. These things make people more likely to attempt suicide. So those are the groups that we really want to be cautious with. And the way to really help those patients is to do a thorough assessment. You know, you don't want to just do like a hi-by, drive-by, you know, that would be where you would miss something and someone would be at greater risk.
So what are some of the signs, and what can you do to try to, you know, help someone or prevent that suicidal tendency or act from happening?
One of the biggest signs that I would watch out for is a very sudden change in disposition. And that can be either in a positive direction or a negative direction. So if somebody suddenly, you know, they've been depressed, they've been down, and suddenly they're like very enthusiastic, very happy, and combined with that, they're saying things that can be interpreted as like a goodbye, like, oh, I just want you to know when I'm not around how important you were to me. Like things that seem like a goodbye are things to be very cautious of. Or a sudden change in disposition where somebody who's usually happy is suddenly just flat or withdrawn. Somebody who used to do things and now suddenly does not leave their room, has trouble getting out of bed. And end of life preparation, which can be tricky with geriatric patients because it is normal to kind of have your stuff in order. But at the same time, if they're suddenly out of nowhere very fixated on it after, say, the death of a loved one or after a stroke, you might want to think like, hey, are they not happy with living anymore?
Yeah, and you're absolutely right. It is something that we should all be thinking about as far as pre-planning. So that's a tricky one for sure, because a traumatic event can make you you know, get ready for those things. But it's definitely that's definitely an interesting one to put on the list for sure, to look out for. Now, is there anything you can do to prevent it? You know, everyone that has gone through something like this, and a lot of us have, you know, we always ask ourselves, is there something that I could have done? So we've talked about signs and symptoms, but is there something that you can do to help a loved one that you feel is going through this experience?
Yeah, and that's something that is also very complex in itself because a lot of times you can't control what other people do. You know, if someone has, say, substance abuse issues, which are very intertwined with suicide, or if someone's refusing to get help, it's very important for caretakers and loved ones to know that they can reach out, they can help, but that they are limited, that sometimes there's only so much you can do. So I want to focus on, of course, the things that we can do proactively to help these patients. It would be making sure that they are getting treatment, making sure that they are going to their appointments, regular appointments, psychiatry appointments, counseling appointments, trying your best to get them out of the house, trying your best to make sure they're eating, getting some exercise, and just maintenance, like not waiting until it becomes a crisis, but starting to go to therapy after an event that is traumatic, or you know, at some point where even everything's fine, starting counseling then, so that I like to think of it as like with a car, you don't want to wait till you're broken down by the side of the road. You want to make sure your car is getting regular maintenance. So that would be what we can do to help these
Good analogy.
patients. Yeah. very accurate one. But I want to reduce the strain on caregivers too, because there are some patients that, working with them, they don't want to be proactive in their care. And I want the caregivers to understand and not experience excessive feelings of guilt, because there's only so much you can do, and you want to be proud of what you did and proud of how you help people, but you don't want to feel as though you're single-handedly responsible for everyone.
Absolutely. That's a real thing right there. Now at Park Royal Hospital, you guys do a multitude of different things, but what do you do for your patients that are having those suicidal thoughts?
So one thing I'm really proud of that we do is a very thorough approach. It's not just like, okay, let's slap Lexapro on it and there you go, here's your 30-day supply. Next. We see a patient, we have the nursing team assess them, our clinical services team assess them, the psychiatrist assess them, and then we have our treatment team meeting. So everyone is on the same page. So a lot of times a patient will present well because they just want to go home and they don't want to talk about what's really bothering them deep down. And it's good to have that interdisciplinary work, because then we sit down and the nurse can actually be like, well, I know they told you they're fine, but I heard them telling their brother on the phone that they're probably going to kill themselves when they leave. I've heard things like that, and it's good that we're all on the same page. And I don't know how we could possibly function as well as we do without that. We work pretty closely with the family. So a lot of times the picture that the patient paints for us is not at all what the family is seeing, and we can work together to kind of make a stronger discharge plan and treat the patient better. Because sometimes the family will mention hey, I don't know if they told you they have a huge substance abuse problem. And we're like, wow, no, they said they drink on occasion. And we can treat them better when we know more. We also do a very thorough approach with labs. So my supervising doctors are very big on making sure there's no organic cause, like a thyroid issue, vitamin deficiency, anemia. All these things can contribute to mood problems. We even use a lot of L-methylfolate or Deplin. Some people are deficient in that, and that helps with your serotonin levels. So we're we look at the whole picture. We do referrals to counseling, and we do step down to PHP, IOP, and we also have options for treatment-resistant depression. So we can refer patients to ECT, which happens at our facility, both inpatient and outpatient. And we can also refer patients to other places that do things like ketamine therapy or TMS, the magnetic stimulation, to help with treatment-resistant depression.
Yeah, and we've done some really great talks on ETC with Park Royal. So if anybody's interested in learning more about that, it sounds pretty intimidating and pretty scary when you say it out loud, but it's really not. It sounds like it's for those people that are at the end of the rope and they really don't see any other options. It can be a very effective form of treatment.
I love ECT. I tell patients, I tell them I would do it in a heartbeat if I was in your situation. Yes, there can be some mild memory loss after, but if you're living in a state of depressive fog, your memory is probably not good anyways, and I would take the memory loss over it in a heartbeat. I'm so grateful that we have that option.
I agree. Well, thank you for coming on the show today, Lisa. This is a very important topic, and we've got to, break the stigma on mental health and continue to talk about it in ways that we can help our family and not bury our head in the sand and pretend like it's not happening. So appreciate your time this morning.
Of course.